Welcome to the Deep Dive. If you are anywhere near the world of healthcare, you know that the pace of change, it's not just fast anymore. It's relentless.
It really is. It feels like warp speed sometimes.
Exactly. Technology, policy, the way we even think about delivering care. It's all colliding. And this massive turbulence is demanding a whole new kind of clinical leader, someone who's just as comfortable, diagnosing a complex patient as they are designing a sophisticated data infrastructure.
That's the perfect way to frame it. The two are becoming inseparable.
Okay, let's unpack this. Our mission today is to pull apart a really dense stack of sources. We're talking core informatics, we've got strategic management frameworks, even some leadership philosophy.
A little bit of everything.
And the goal is to synthesize all of it, to define, what are the exact competencies for the doctoral-prepared advanced practice nurse, the APN. We want to know what it takes for them to not just manage, but to really lead in this new world.
And that distinction you just made between managing and leading, or as the sources say, from proficient user to system architect, that is the core challenge. The doctorally prepared APN, so your DNP or DRNP, they must have a significantly higher level of technical competency than their master's prepared colleagues.
So we're moving past just being good at using the EHR, the electronic health record.
Oh, way beyond that. That's the baseline now. We are talking about stepping into expert leadership roles in the actual design, the selection, the implementation, and then the really rigorous evaluation of health technology.
So if a master's level nurse is an expert at driving the car, the doctoral APN needs to be the chief engineer who helped design the engine and the navigation system.
That is a perfect analogy, exactly. And the stakes are so high because their roles are just so varied. I mean, they could be a practitioner leading complex new protocol.
Or an educator.
Or an educator designing the informatics curricula for the next generation. Or a clinical scientist or an administrator managing a multi-million-dollar budget. The setting doesn't matter. That expert proficiency in IT isn't optional anymore. It's just mandatory for any kind of large-scale impact.
And this mandate, it didn't just appear out of thin air, right?
Not at all. It really stems from years and years of intense scrutiny. You have to look back at those major reports, especially from the Institute of Medicine, the IOM. They were consistently calling for a fundamental restructuring of how we educate all health professionals.
And what was the IOM specifically demanding? What put informatics right at the center of the conversation?
They mandated a foundational emphasis on three things. First, informatics integration. Second, really robust evidence-based practice. And third, continuous quality improvement.
The big three.
The big three. The thinking was, and it still is, that you just cannot transform a complex, fragmented system without leaders who understand how information flows, how to generate and apply evidence, and, how to actually measure if you're getting better.
And so the doctoral APN is now positioned right in the middle of all that.
They are squarely positioned as the leader who is expected to drive these systemic changes, to be that person who integrates data and practice at the absolute highest levels of an organization.
Okay, so let's start there with that big picture. Leadership. We're not talking about just managing the schedule on a single unit anymore. This is about redesigning the entire business of care.
That's right. The American Association of Colleges of Nursing, the AACN, was very clear on this, even way back in 2006.
What did they say?
They stated that doctorally prepared nurses must assume key leadership positions. And these aren't just supervisory roles. They're specifically designed to drive system-wide changes and to ensure nursing participates actively in executive decisions.
So a guaranteed seat at the C-suite table.
If we connect this to the bigger picture, that seat is absolutely necessary. The whole goal is nothing less than transforming the U.S. healthcare system.
Into what exactly? What's the end game?
The end game is a seamless, coordinated, and sustainable care environment. And this whole transformation is universally measured against a standard framework you've probably heard of. The outcomes defined by the triple aim.
The triple aim. It sounds simple enough on paper, but I know that achieving those three goals at the same time is what makes this so incredibly difficult.
It creates this inherent tension, and the doctoral APN has to navigate that tension every single day. The three goals are non-negotiable. First, you have to improve the health of entire populations.
So moving beyond just the one patient in front of you.
Right, looking at whole communities. Second, you have to provide a better care experience, and that includes both the hard metrics of quality and the softer but equally vital metrics of patient satisfaction.
And the third leg of that stool is the one that causes all the friction, isn't it? The money.
It usually is. You have to lower costs through continuous improvement. And the doctoral APN needs to be fluent in designing clinical processes that actually achieve all three of those, not just, sacrificing one for the others.
And the sources are really clear that nursing has been designated as the primary change agent to make all this happen. That is a huge burden of responsibility.
It is, but it's an earned one. The expectation is that nurses will practice to the full extent of their doctoral education.
Which now includes this deep expertise in systems and data.
Exactly. And that they'll serve as full partners with administrators, with physicians, with other health professionals in redesigning care. It's a fundamental shift in perspective.
So instead of focusing only on the patient in the room,
they also have to focus on system-wide processes, financial outcomes, and population health metrics. They are focused on the entire system that surrounds that one patient.
So to manage change of that magnitude, you can't just wing it. Leaders need a solid framework, which is where strategic management comes in.
Right. Strategic management is the compass for the leader. They have to rigorously align the goals of their department or their initiative, whatever it is.
Like a new EHR rollout or something.
Exactly. They have to align that directly with the organization's big overarching principles. Its mission, so why it exists, its vision, its aspirational future, and its core values. If a project doesn't align with those, it's a wasted resource.
So this requires some serious futuristic thinking.
It does. You have to anticipate where healthcare policy is going, where workforce demographics are headed, and where technology will be in 5, even 10 years from now. You're essentially planning for the organization's survival.
When you talk about anticipating trends, it just highlights how volatile healthcare is. This brings up an idea from the sources. The organization as a complex adaptive system, a CAS. I think that's a term a lot of people might not be familiar with.
It's a concept that's borrowed from complexity science, even chaos theory, and it perfectly describes modern healthcare. Just think of a busy emergency department. It's a system with these dynamic, nonlinear relationships among countless agents. An agent could be the patient's disease, a sudden staffing change, a new electronic alert, a pharmacy delay. They all influence each other in unpredictable ways.
So you can't just plan for one thing to happen.
Never. This high level of dynamism means nurse leaders have to be incredibly proficient at what we call environmental scanning.
And environmental scanning isn't just, reading the news. It's a formal intelligence gathering process, right?
Yeah.
What are they looking for?
They are continuously monitoring and assessing critical areas. Internally, they're looking for the organization's competitive advantage, they're analyzing operational effectiveness, and they have to understand the culture. Is it actually ready for change?
And what about externally?
Externally, they're looking at new partnerships, shifts in the market, and critically managing the sheer explosion of information the organization has to process. All this intelligence helps them apply a strategic analysis approach so they can be proactive, not just reactive, in what is fundamentally a chaotic environment.
Okay, that strategic backdrop makes a lot of sense. So with that in mind, let's get into the technical requirements, because this seems to be where the doctoral APN really separates from the master's prepared nurse.
It is. The master's nurse must achieve proficiency.
Right. We said they're proficient users of the tools. They can expertly chart in the EHR. They use communication tech. They understand basic data management.
Precisely. They are skilled facilitators of the system as it exists. But the doctoral APN, they must possess high-level skills and assume system leadership.
So the DMP isn't just using the tool.
They are responsible for how the tool is designed and integrated into the whole system, ensuring it meets those triple aim outcomes we talked about. They have to be able to critically question the data structure itself.
Now, that distinction brings us right to the AECN's Essential 4, the mandate for doctoral education. It says the doctoral APN must demonstrate abilities to use information systems and technology to sustain and improve patient care and healthcare systems.
Right.
What are the concrete actions required under that essential?
Well, there are several key leadership competencies. First, the doctoral APN must lead the design, selection, use, and evaluation of technologies. This isn't a passive role at all.
So that means sitting down with the vendors, with the IT department, and being able to speak the language of both clinicians and engineers.
You have to be the translator, absolutely. Second, and this is critical, they must actively design and implement mechanisms to extract data from all these different information systems.
So they aren't just asking IT for a report.
No, they're building the capability. They're creating the structure, the queries, the data dictionaries, the extraction pathways to pull meaningful, actionable data out of all those system silos. They're turning raw data into actual evidence.
This idea of generating knowledge leads us right to that foundational model of nursing informatics, the DIKW meta-metastructure.
Data, information, knowledge, and wisdom. Yes.
Can you break that down for us?
Of course. The American Nurses Association relies on this framework. It's a hierarchy. It starts with data just discrete, raw facts, a single lab value, a single temperature reading.
Okay, just a number.
Just a number. That data becomes information once you organize and interpret it. So a chart showing the temperature trended over the last 24 hours.
So it has context now.
Yeah, it has context. That information is then synthesized into knowledge by linking relationships and seeing patterns. The DNP recognizes that the temperature trend, combined with a dropping white blood cell count, probably indicates sepsis.
Okay, what about the top of that pyramid?
Wisdom. Wisdom is the ethical and judicious application of that knowledge to solve complex human problems. So in the sepsis example, wisdom is applying the protocol, knowing what resources you have, communicating the crisis effectively, and then reflecting on the whole thing to improve the process for the next patient. The doctoral APN has to operate at that top level, at the knowledge and wisdom level.
Which means they have to take a leadership role in knowledge management systems to generate what our sources call practice knowledge.
Yes, practice knowledge is the critical output of the DNP's work. It's what happens when you systematically combine information from all these different data sources to create new knowledge that actually contributes to the evidence base of the profession.
So it goes beyond just applying existing research.
It does. It's about actively contributing new scientific knowledge based on real-world practice data. You're closing that gap between research and what actually happens at the bedside.
But to make any of this visible, especially practice knowledge, you have to be able to measure it consistently. And that's where standardized nursing language, or SNL, becomes, well, non-negotiable.
Championing SNL is absolutely essential, and here's why. Historically, the impact of nursing care, the specific things nurses do and the outcomes they produce, has been invisible in the data.
Because everyone was just free texting their notes.
Exactly. And if you can't measure it, you can't manage it, and you certainly can't get paid for the value you're providing. So SNL has to be integrated with universal terminology like LOINC for labs and SNOMED for clinical terms.
So if a nurse charts patient ambulated 50 feet post-op without SNL, it's just a note. But with SNL, it becomes a standardized data point.
It becomes a standardized intervention that can be aggregated and analyzed across thousands of patients. Then you can actually demonstrate how nurse-led mobility programs impact length of stay or reduce complications.
It makes nursing's value visible in the data.
It makes nursing data visible, it improves communication, it enhances data collection for research, and most importantly, it ensures the impact of nursing care is measured for quality and financial outcomes. Without it, nursing just looks like a cost center.
Okay, let's pivot to the specific skills needed to manage all this data. The Tiger Informatics Competency Collaborative gives us a good framework here.
Tiger identifies 3 core skill categories: basic computer competency, information literacy, and information management. For the doctoral APN, the emphasis is heavily on the high-level skills within information literacy.
And this isn't just knowing how to Google something.
Not at all. We're talking about the ability to determine the nature and extent of information needed for a complex systems challenge, then being able to access that information efficiently.
But the critical skill is what?
The critical skill, the real high-level competency, is the ability to evaluate information and its sources critically. In this age of digital misinformation and, commercially biased data, the DNP has to be the quality control filter for digital evidence before it gets integrated into practice.
So to succeed at that, the doctoral APN needs to achieve something called information mastery.
Yes, a concept from Slauson, Shaughnessy, and Bennett.
Information mastery. That sounds like the ultimate defense against the information overload every clinician feels.
That's precisely what it is. The central idea is that the most important information must be highly relevant, highly valid, and critically take very little work to obtain.
It has to find you. You can't be hunting for it.
Exactly. It needs to address common or critical clinical questions, focus on patient outcomes, and be potentially practice-changing. If a clinician has to dig through 100 articles to find an answer, They just won't do it.
And the DMP's job is to design the system so that the right information gets to the right person at the right time.
That's it. But our sources noted a scholarly gap here.
Really?
Yes, a literature review showed a surprising lack of nursing research on applying information mastery. The existing work was overwhelmingly focused on physicians.
So the tools being designed are bypassing nursing leaders.
It seems so, which means doctoral APNs are uniquely positioned and frankly required to close this gap by developing nursing-specific models for filtering and delivering this information at the point of practice.
And closing that gap means doing serious clinical scholarship, which requires some heavy-duty tools.
Absolutely. For quantitative analysis, looking at large trends, staffing ratios, readmission rates, they need proficiency in statistical tools like PASW, which used to be SPSS, or SAS. They're using these to correlate nursing interventions with financial and quality outcomes.
And what about the qualitative side of things? The why behind the numbers?
For that, they need software like Atlas or NVivo. These tools let them analyze textual data like patient narratives or focus group transcripts to understand experiences. Qualitative research is gaining a lot of ground, and the DNP needs to be able to bridge both methods.
And then they have to present all of this synthesized information in a way that the C-suite and the bedside staff can actually understand and use.
Yes, and that means being proficient in report generation tools like crystal reports. These are essential for pulling together meaningful, visualized information from all those different data sources, the EHR, billing, staffing to support data-driven decisions.
This all seems to be aimed at integrating knowledge directly into the workflow, which brings us to clinical decision support, or CDS.
CDS is one of the most powerful tools informatics offers. It's an attempt to deal with the fact that no single human can possibly keep up with the exponential growth of medical knowledge.
So CDS integrates that knowledge right into the system at the point of care.
Right. And it can take many forms. It's not just a pop-up alert.
So what are some other examples?
Well, it could be standardized documentation templates that guide you to collect the right information. It could be how the system presents data like automatically showing the last 3 blood pressures alongside medication changes to highlight a trend.
That's smart.
It includes order creation facilitators, protocol support, hyperlinks to the latest guidelines, and yes, the reactive alerts and reminders like a drug allergy warning.
But you mentioned a critical gap in the research on CDS earlier.
I did. While the potential is huge, the fact remains that most existing CDS work and research has historically been about physician practice. There's far less research on what CDS systems are available to or used by nurses who spend the most time with patients.
So we need doctoral APNs to study this.
We need them to study, develop, and evaluate CDS systems that are specifically tailored for nursing practice. We need to move beyond systems that just record what nurses do to systems that actively support their complex, real-time decision-making.
You know, any discussion of these systems immediately brings up the importance of workflow. This is where so many of these tech initiatives just fall apart.
The sources are crystal clear on this. The single biggest reason for technology failure and poor adoption is that the tech just doesn't support the clinician's workflow.
And when a system doesn't make sense, people find workarounds.
Dangerous workarounds that bypass safety features. This is why the doctoral APN needs high proficiency in workflow and mind mapping software, things like SmartDraw or Visio.
Why is physically mapping out the workflow so important for a leader?
Because you cannot fix what you have not seen. The DNP has to lead teams to map the current state workflow, documenting every manual step, every piece of paper, every frustration, and then design the desired future state workflow that the new technology is supposed to enable.
And that map becomes the blueprint for training and implementation.
Exactly. By getting rid of illogical or redundant steps, the DNP leader ensures the technology is seen as a help, not a hindrance. That's how you reduce the administrative burden and give nurses more time for direct patient care.
All right, so if a doctoral APN goes down the administrative track, they become the nurse administrator. Their main job shifts to managing healthcare delivery services and representing nursing at the executive table.
Right, and they're constantly navigating this really challenging landscape of legal, regulatory, ethical, and evidence-based care issues.
And to manage those services, they have to understand the very structure of the organization they're in.
Correct. They have to be fluent in different organizational structures. You often see the functional structure where the organization is divided by purpose, like all surgical units reporting up one chain.
And in bigger organizations.
In larger organizations, you'll see a divisional structure organized around service lines, like a heart center division or a women's health division. That structure can often meet specific patient needs a lot quicker.
And then there's the really complex one, the matrix structure.
The matrix is a combination of functional and divisional. For a nurse leader, that often means reporting to two different bosses, a functional leader, like the chief nursing officer, and a divisional leader, like the VP of the cancer center.
That sounds like it could lead to some real power struggles.
It can. While it's designed to be flexible, leaders have to be acutely prepared for the conflicting priorities that are often inherent in that structure. You have to be a skilled negotiator to succeed there.
Let's pivot to the force that's driving a lot of these structural shifts, healthcare financing. It feels like for a doctoral APN leader today, ignorance of finance is basically malpractice.
It's absolutely non-negotiable. The industry has shifted dramatically away from the old volume-based fee-for-service model
towards value-based payment.
Exactly. Key components include value-based purchasing, or VBP, where payment is tied directly to your performance on quality indicators like patient safety scores. This means the nurse leader has to have deep knowledge of Medicare rules, inpatient payments, and the huge penalties a hospital can face for things like too many readmissions or hospital-acquired conditions.
They are stewards of multi-million-dollar budgets.
They really are. And VBP is tied directly to the rise of accountable care organizations, or ACOs.
Which is the ultimate financial responsibility model, right?
It is. In an ACO, providers assume much more financial and clinical risk for the care of their covered populations. The goal is to improve costs by improving quality and efficiency, cutting down on redundant tests, expensive drugs, and, crucially, preventing those readmissions.
And nurse leaders are fundamental to the success of an ACO.
Absolutely, especially those focused on care coordination. They have to be fluent in performance data, benchmarking, and sophisticated cost analysis to prove nursing's contribution to the bottom line.
A system so focused on reducing errors and improving outcomes has to rely on the principles of high-reliability organizations, or HROs.
An HRO is the gold standard. It's an organization that operates under incredibly high-risk conditions. I mean, the daily chaos of acute care, yet manages to have far fewer bad outcomes than you'd expect.
And they do this through 5 core characteristics that the DNP has to embed in the culture. Can you walk us through those?
Sure. First, they have a preoccupation with failure. They don't celebrate success. They're constantly hunting for what could go wrong next. Second, a reluctance to simplify. They resist easy explanations for complex problems.
So they don't just blame one person.
Never. They analyze the whole system. Third is sensitivity to operations, meaning leaders know what's really happening on the front lines. Fourth is a commitment to resilience, the ability to spot errors early and recover quickly.
And the fifth one, deference to expertise, seems especially important in a hospital setting.
It's transformative. It means the person who knows the most about the problem at hand leads the response, regardless of their title. If a new grad nurse sees a sterile field break that the senior surgeon misses, deference to expertise means that new nurse's concern is heard and acted on immediately.
That requires a lot of psychological safety.
It's foundational. And to maintain this HRO environment, you need specific communication tools. The leader has to champion their use.
Tools like SBR.
Absolutely. SBR, situation, background, assessment, recommendation, is fundamental for clear, concise communication. We also see STAR, Stop, Think, Act, Review used as a kind of internal check against distraction before a critical task.
And what about RUC?
RCC gives staff a clear pathway to escalate safety concerns. Ask a question, request a change, voice a concern, and use the chain of command. It empowers anyone to speak up without fear, which is the heart of an HRO.
Okay, moving from systems to the human element. The link between proper staffing, productivity, and performance is well documented. So the nurse leader is also the champion of human resource management.
That's right. And when we talk about the philosophy of leadership here, we have to start with that powerful quote often attributed to Jack Welch.
Before you are a leader, success is all about growing yourself.
When you become a leader, success is all about growing others.
That really sets the tone for the doctoral APN. Their success is defined by their team's capabilities.
It is. Leadership is seen as a choice, not a title. It's built on the ability to listen, to observe, to learn from mentors. True doctoral leaders create a protected, safe learning environment that supports caregivers, inspires growth, and models that essential skill of lifelong learning.
And that ability to grow others often happens through mentorship. One of our sources had a great personal anecdote about this.
It's a wonderful story. The speaker recalled their first nurse preceptor who was teaching them how to care for post-open heart surgery patients, which is incredibly complex. And the key wasn't just the demonstration, it was what happened when the new nurse inevitably struggled. The preceptor didn't just take over or shame them, they encouraged the nurse to try again and again until they gained confidence. It's about showing the path and pushing others forward when it gets tough.
And to make that kind of supportive environment sustainable, the leader has to actively create and maintain a healthy work environment.
They should use established frameworks like the AACN's Healthy Work Environment Standards as their blueprint.
And what are those standards?
There are 6. Skilled communication, true collaboration, effective decision-making, appropriate staffing, meaningful recognition, and authentic leadership. It's a comprehensive plan for fostering excellence and fighting burnout.
Now, to implement any of these huge changes we've talked about, you need expert change management. The nurse leader has to master change theory.
They do. Change models are their roadmap. One of the most robust is Cotter's 8 steps. It's a logical process. It starts by establishing urgency. The DNP leader has to show why the change is necessary right now.
By looking at market realities, like new competitors or rising penalties.
Exactly. Then, they form a powerful guiding coalition, an interprofessional team. They create and communicate the vision, effectively marketing the why to the staff.
And once that urgency is set, how does a leader make sure the change actually sticks?
The process moves into execution. You have to empower action by removing obstacles. Then, to keep up momentum, you plan for and celebrate short-term wins with meaningful recognition for the staff embracing the change. And finally, you have to consolidate those improvements and institutionalize the new approaches so they become part of the culture.
We also have Hewittson's strategies, which seem to reinforce this.
They do, by focusing on the human element. First, engage everyone affected in the vision and planning. Second, empower people to take smart risks and innovate. And third, embed what works into the system while ruthlessly getting rid of what doesn't. The DNP has to be the agent who communicates the need, manages the friction, and models the new way of doing things.
Given the relentless pace we started with, the doctoral APN can't just stop learning after graduation. Lifelong learning is an operational necessity.
It is, and they need active strategies to stay current. This means ongoing, advanced training in library search skills. We're talking mastering Boolean logic, using clinical query filters in databases like PubMed and CINHL, and using bibliographic management tools like EndNote to organize the hundreds of articles they're constantly reviewing.
And what about outside of the formal academic world? How do they master the web?
They have to leverage Web 2.0 and 3.0 tools. This means setting up reference alerts, or SDIs, using RSS feeds from key journals, and even using professional networks on platforms like Twitter to get customized, validated content from trusted experts. This all ties into the idea of a personal learning environment, or PLE.
A PLE, a customized knowledge hub.
It is. A tool like NetVibes lets you create a single dashboard that pulls in all those different information streams. It uses the intelligent web to bring the right information to you so you're not always hunting for it. It's how you achieve information mastery in the real world.
Here's where it gets really interesting. Beyond mastering the tools we have now, the doctoral APN has to be looking ahead, anticipating the tech that will completely redefine patient care.
And we are seeing revolutionary tech moving from the lab right to the clinic. Take artificial intelligence, robotics, and effective computing.
Effective computing.
The ability of computers to perceive and respond to human emotions. Imagine how that could change interactions in mental health or pain management. At the same time, AI and robotics will handle more sophisticated caregiving tasks, supporting patients 24/7.
It sounds like the nurse's role is shifting from physical labor to being the cognitive overseer of this whole tech ecosystem.
Precisely. And then consider things like bioelectronics and human-machine symbiosis. Miniaturization is leading to tiny advanced sensors and implants for managing complex neurological conditions. And of course, there's 3D bioprinting.
The ability to create interchangeable body parts, that's still mind-blowing to me.
It's transforming how we think about surgical capacity. And the interfaces we use are changing too. Virtual and augmented reality aren't just for games anymore.
Right. They're used for therapy, like for PTSD, and for hyper-realistic disaster simulation training.
And at the bedside, augmented reality will soon overlay decision support right onto the patient or the environment, giving you real-time vitals and guidance during a high-stress procedure.
So as system leaders, they have to proactively deal with the massive challenges this tech creates.
The two biggest interlocking challenges are interoperability and cybersecurity. For care to be truly transformed, all these systems have to be able to talk to each other to manage the massive amount of data being collected.
And cloud computing is key to that.
It's crucial for portability and access. But when data is portable, the security risk just skyrockets.
And we've all seen the headlines about security breaches.
Absolutely. The risk of hacking connected devices like wireless infusion pumps is very real. The doctoral APN has to work with IT and security teams on proactive measures, but more than that, they have to be the clinical champion for patient privacy and data integrity in the face of these sophisticated threats.
So what does this all mean? We've covered a huge amount of ground today. It seems the doctoral APN role requires this unprecedented integration of two really complex domains.
It does. On one hand, you have deep technical mastery informatics, data analysis, emerging tech awareness. And on the other, you have strategic acuity, the triple aim, HRO principles, financial management, change management.
So their core function is to be the bridge between those two worlds.
That's it. The doctoral APN must leverage these technologies and data to generate more evidence-based and practice-based scientific knowledge. They are the catalyst for continuous, measurable, system-wide improvement.
We've established that these high-level nurse leaders are required to integrate technology into every single aspect of care, from the boardroom to the bedside. They are the essential link, ensuring that technology serves the human element rather than dominating it.
This raises an important question. If the future internet will be fundamentally smarter, capable of real-time analysis, collecting this vast and pervasive data from every sensor and device imaginable, what specific mechanisms must doctoral APNs implement today, as the architects of these systems, to ensure that this pervasive data collection is strictly controlled and applied ethically? How do they guarantee that individual privacy rights are never, ever compromised by the necessary pursuit of big data insights? That ethical leadership, protecting privacy while still driving innovation, that is perhaps the ultimate responsibility.